Hi everybody, welcome to week 13, and as you can see from the slide, today's module is all about infant feeding. So we are going to cover an overview of early breastfeeding, but also importantly we will cover other options available as well to families. So they would include the use of donor milk, mixed feeding, so a combination of breast milk and formula, as well as formula feeding. So a fair bit to get through, but we'll start off very importantly with the doula's role in breastfeeding. So as I said, I think it's important to start off by talking about how we fit into this as doulas and the information that we might provide to clients about breastfeeding. The first thing to just sort of think about really is the timing around this. And if you are a client's birth doula, as in you're not going to be meeting with them outside of the sort of normal and scheduled postpartum visits, then really, you are likely to only sort of be seeing your client in the first couple of weeks after the birth, certainly long enough for mature breast milk to come in and for breastfeeding to have sort of started to become established, but certainly not in the long term. If you are doing extended postnatal support for clients, either through Birth for Humankind or maybe through your own clients, then you may see clients, for the first, maybe up to the first 3 months even postnatally. So a few things that I want to point out on this slide. Obviously, in the same way that we support our clients, preferences and decisions in pregnancy and birth, the same applies for anything related to the postnatal period, including breastfeeding and whatever our client's preferred option for feeding her baby is. As doulas, in the same way that childbirth educators, midwives, for example, would be first and foremost promoting what we would really call the biological norm, which is breastfeeding. But at the same time, it's really important that we sort of, again, do that internal check about our own biases, and recognize that, that there will be women who will opt to formula feed or mixed feed. That may have absolutely nothing to do with, her actual ability to breastfeed. It may be just a personal choice, which we must respect. For clients who do plan to breastfeed, and I would say that the majority of women would like to breastfeed and certainly would like to give it a really good go, and the research definitely supports this. It is important for us as doulas just to have a good general knowledge of breastfeeding. So that would include things like breast anatomy. In your student workbook, one of the things you'll see as part of the sort of homework assignments is an anatomical drawing of the breast, and I'd like you just to sort of draw arrows, if you like, or to annotate that anatomical drawing with certain features of the breast. So that just gives you a very basic overview. Breast milk synthesis, so how is breast milk actually produced? And again, given that we are primarily talking about the role of a birth doula as opposed to a postpartum doula, really our interaction with clients is really in those first few weeks. So it's important in terms of our overall breastfeeding knowledge that most of that comes from early breastfeeding. So that I suppose progression from colostrum, which is the first milk which is already in the breast before birth, and that transition through to mature breast milk, and again what's sort of happening in those early weeks as breast milk production sort of ramps up, hopefully to a point where your client has a good and steady and reliable flow and production of milk production. Again, from breastfeeding research, we know that when women can get to that sort of magic 6-week mark, and if she's still breastfeeding and the feeding is generally going well, that she will have a very high chance of continuing to feed for as long as she chooses to, or however long that relationship that she and her baby, really benefit from. So, I often really try and reinforce this with clients, both doula clients and birth education clients, that when it comes to breastfeeding, it's really important not to sort of overly fixate on those first few days, that really they should sort of get their head around the first 6 weeks. And see that as really the goal of those 6 weeks is to build supply. And if she can get to 6 weeks, she is generally sort of home and hosed. If your client has a partner, we want them to understand also how breastfeeding works. One of the sort of, I think one of the most interesting little factoids that I have about breastfeeding is that we know that the #1 determinant of breastfeeding success is partner support. I often ask this in class, and I ask clients, what do you think this #1 factor is? And most people will say, oh, how much milk you have, breast size, all of these sort of very sort of physical aspects of, they imagine it relates to breastfeeding success, and everybody is surprised to hear that. So we want our partners to understand that they do play a very, very big role. Their support, their encouragement, their facilitating to basically allow mum to have the time to breastfeed, because in those early weeks it is so time consuming. She won't have the time or energy to do a whole lot of other things. If she's not sleeping, or feeding or caring for the baby in some way, there's not a whole lot of other time left in the day. So if partners can kind of pick up that slack and really help around the home, help with meal preparation, help with cleaning, having the baby, those periods in between feeding when they can do lots of, skin to skin with partner, with dad, playing and interacting and bathing and all those other things that, partners can do everything except breastfeed. So, and there's a lot of other things, that are involved in caring for a baby. Excuse me. It's really, really important, again, to stay in our lane and also recognize, again, our sort of scope of practice as doulas. We are not lactation consultants or breastfeeding counselors. So it's really important not to sort of be diagnosing breastfeeding related issues or problems, like tongue ties or blocked milk ducts or thrush or, any of these things. If she has a concern, then what we do want to do is to refer her on to a qualified professional. That could be her midwife, the maternal child health nurse. What I would say, though, is the best support is going to come from breastfeeding experts. The ABA, the Australian Breastfeeding Association, is fantastic. They also have live chat and live phone support 24/7. And of course, if she has the financial means, then connecting with a local IBCLC, which is a internationally board certified lactation consultant. Unfortunately, they're not cheap, they're not bulk billed, they're not covered by Medicare, which I can say a whole lot of other things about, but I won't because we've got a lot of stuff to get through. The hospitals obviously also have a breastfeeding sort of drop-in clinic and, support services there as well. So she will be able to go back to where she had her baby anytime if she's got concerns or she wants some support around breastfeeding. But I really do think that, the best breastfeeding support is going to come from breastfeeding experts, and the ABAs, as I said, IBCLCs are really where she's going to get not just the best support, but the best advice. It's going to be evidence-based, it's going to be current, and they're going to be experts in that field. GPs know next to nothing about breastfeeding. The amount of breastfeeding education and training they would have done during their general sort of practice training would probably be about 4 or 6 hours in their entire medical degree. So that'll tell you, and especially if you're seeing a doctor, if your GP is in their 50s or 60s, then that breastfeeding education is probably about 30 years old. So you can sort of see why it's really, really important that women do seek out, breastfeeding advice from a qualified professional. Also things like, for example, if your client needs to be on medication for something, GPs often are, because again, they're so woefully kind of, inexperienced, and when it comes to information around breastfeeding, if a patient of theirs needs to be on medication, almost all medications will say contraindicated with breastfeeding. It's just purely about the pharmaceutical companies, saving them their behinds and making sure that they aren't leaving themselves wide open for lawsuits. So GPs are also equally kind of apprehensive about either prescribing medication, or if they do, because the mother genuinely needs it, they'll say, oh, while you're on this medication, you shouldn't be breastfeeding, this very crude term, pump and dump, to keep the supply going, just get rid of that milk, is in most cases absolute rubbish. There are very few medications which a woman can't take while breastfeeding, very, very, very few. And in the case of those few drugs where it is contraindicated, in some cases there is an alternate medication which can be prescribed. So things like that, again, GPs, really don't have the scope of knowledge to really help a mother, and to really help to encourage her to keep breastfeeding if there are sort of certain issues going on. Okay. So as I said, sort of in the last slide there, that one of the things that's really helpful, I think, for us as doulas to know is just to have a really basic understanding of breast milk production and how that process actually takes place. I won't read through this whole slide because obviously you guys can do that in your own time. You'll have access to the slides separately, or you can just pause the video and have a read. The only things I really just wanted to point out is that, in its most simple sort of term and sort of, I suppose, understanding of the function of breast milk production, is that it is a demand and supply sort of issue. We often talk about supply and demand, but in breastfeeding, it's the other way around. It's demand, as in the baby demands to be fed, and the breast will then therefore supply the food. And the more that babies stimulate the breast, the more her breast will produce milk. And really the most important thing to share with clients in these early weeks is that in order to build a reliable and sustainable supply of breast milk, it's really, really important that she keep a close eye on her baby's hunger cues. So all those little signs really early on that her baby's giving her that, they're hungry. And one of the videos you guys will watch is a cute little video of just a few minutes long of 8 classic hunger cues that babies give. And these are really universal kind of signs and indications. So feeding on cue and feeding, really for as long as baby shows any desire to continue feeding. You cannot overfeed a breastfed baby. And it's also really important to forget about this idea that you can put newborn babies, and particularly breastfed babies, on any kind of schedule. Schedules and sort of these rigid routines around sleep particularly, and breastfeeding simply don't go together. And I think that's really, really important to share with families. Again, we have to go back to what are the goals? What are her goals or the family's goals around infant feeding? And if she has a strong desire to breastfeed, then we've got to help her to understand what is going to actually promote successful breastfeeding and what is likely to sabotage. And scheduled feeds is a clear saboteur. Things like topping up with formula unless there's a medical need to do so. Using dummies or pacifiers in those early weeks, because that's a really easy way to miss babies' earlier hunger cues as well. So there's a range of things which really, really can impact early breastfeeding success. So as I said, if you prefer to just pause now and have a read, do so. Otherwise, if you want to continue on, you can always refer back to the slides later and read through them. So for the next few slides, we are going to cover a range of really common breastfeeding problems or issues that a lot of new mums deal with, particularly first-time mums as well. So you can see on the slide here, these are the ones or the areas that we're going to kind of cover off. So latching problems, engorgement, sore or cracked nipples, thrush, mastitis, and ties. So some of these you might have heard of. If you yourself have breastfed, you may personally have experienced some of these issues. I do also want to emphasize that it is 100% the same way. There's no requirement for a doula to have given birth in order to be a good doula. There's no, you don't have to have breastfed in order to be able to, again, be a supportive doula providing really good, balanced, evidence-based information about breastfeeding. It is completely irrelevant. And in fact, sometimes, when people have had, really, really problematic breastfeeding experiences personally, again, I mentioned earlier about checking your personal bias. Sometimes that can really cloud, your views and the advice that you give and so forth. So, personal lived experience really, really doesn't play much of a role here. The only reason I pointed it out is that in terms of just your familiarity with some of these very common problems you might personally have experienced. So I remember a good friend of mine a few years ago who is an incredibly experienced IBCLC and midwife said to me that, it's really well acknowledged that probably 90% of breastfeeding problems really stem from a poor latch. If fundamentally, if the baby is not attaching well to the breast, it is kind of like the gateway to 1,000,001 other problems. One of the big problems that happen again with the first baby, and you can see here what I've written on the slide, is when the baby latches onto the nipple only. We call this nipple feeding, right? The fact is that there are multiple holes around not just the nipple, but the areola. And those holes are essentially the outlet point for a vast network of milk ducts in the breast, all of which milk will travel through. So there are multiple openings in the breast that milk can come through, and it's really important, therefore, the baby gets as much of the breast in their mouth as possible. If the baby's only feeding on the nipple, number one, it's incredibly painful for the mother and will lead very quickly to damaging her nipples. And secondly, you'll have a really frustrated bub because they're getting hardly any milk. And so when you've got a really kind of, overtired, very sore, unhappy mum and a hungry, frustrated little baby, you can see how that little kind of combination is kind of a recipe for disaster. If the baby, or by some other means, hand expression, a breast pump, if something or somebody is not extracting the milk from that breast, it will very, very quickly lead to blocked ducts, which again will then lead to mastitis, which is an inflammation of an infection of the milk ducts, and that can be extremely painful and really must have medical attention. So we don't want to get there. We want babies to latch well. We want to see that they are feeding well, that they're getting lots of milk, and that mum is not experiencing pain when breastfeeding. Again, I think that's a really common urban myth, that breastfeeding is kind of meant to hurt, and it's not meant to hurt. It might in the very first few days or first couple of weeks might be a little uncomfortable because babies have got a really powerful suction and suck reflex. So it should feel like a sort of a strong sucking sensation, but it shouldn't be painful. If your client is telling you, oh, it's really painful when the baby feeds, more often than not, there's a latching issue there. And I mean, if she's comfortable and you're comfortable, and you want to have a look at how that baby is latching to the breast, if you see that really that baby is only latching onto the nipple, you can tell her that. And what she needs to do is very simple. She needs to use her baby finger. She needs to pop it between the baby's mouth, corner of their mouth, and her breast to release the suction. Then to gently take the baby off the breast and reposition them and wait for the baby to latch properly. You can see in this little photo, baby's got a really big open wide mouth. When baby is really close to the breast, they can smell the breast milk. So what will happen is the baby will have a very instinctive reflexive action of a big wide mouth. And so ideally what you want, what she wants to be able to do is wait for that big wide open mouth and then to line the baby's bottom lip up with the bottom of her areola. And once they've got into contact, then you can gently just support baby to take the rest of the areola into their mouth. So really we want to try and cover as much of that with baby's mouth. It's important also that the breasts go as far back into baby's mouth as possible. If the nipple is even pointing upwards towards the back of the roof of the mouth, that's ideal. Because then the breast is essentially making contact with the soft palate, which is the softer part of the roof of your mouth the further back you go. And that will also force the baby to engage all the muscles in their jaw and in their cheeks, and to really then encourage that what we call the let-down reflex. There will be very little direct connecting with the nipple itself. It'll be kind of just floating above the top of baby's mouth. And in the very beginning of the feed, you'll often see that the baby will have quite frantic sucking. And what they're trying to do is to create, and to stimulate that let-down reflex. And then some women do feel it, others don't. But eventually what you'll see is a change in the baby's sucking motion. And it will go from, fast suck, 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 suck to suck, suck, swallow. And if you're sort of watching carefully, if she's looking at her baby, she'll see that rhythmic slowing down of the jaw, and then she'll hear swallowing noises. So that's sort of one of the things you want to look for. One of the things I'll also post that you can have a watch of is a website by a really renowned international sort of breastfeeding expert and pediatrician whose name escapes me at the moment. My brain's gone completely flat, but he's brilliant, and he has a fantastic website, and on the website he has a very, very large sort of library of videos. So if you want to sort of have a video which you can show a client, this is what good latching looks like, that's Jack Newman. I knew it would come to me. Dr. Jack Newman is the guy, and so he has this fabulous sort of vast library of videos showing every possible thing relating to breastfeeding you can imagine. And he also has a lot of resources in multiple languages. So I'll send you the link to his website. It's just a very good resource for you. So latching issues, as I said, this is really the sort of the core of where many breastfeeding issues kind of lie. Okay, so this slide is looking at engorgement, and we're looking at what is really the start of quite a sore breast. Engorgement is very normal though, and in fact the first time that a new mum will experience engorgement is when her mature breast milk comes in. So that could be sort of on average I would say 3 to 4 days after the birth, sometimes a little bit later if she's had a cesarean section. And the sensation is that the breasts are very full, they're very tender, they're a bit, tender to the touch and heavy, and she might also be noticing leaking as well. So engorgement is simply when the breast tissue has overfilled with milk and blood and other fluids, and it's really important to start to empty the breasts there. Some women find that if their breasts are engorged, it's a little bit uncomfortable initially to feed babies straight on the breast. So one of the things you can do is just she can go into a nice hot shower and just sort of massage the breast in a downward motion, and to hand express some of that sort of engorged tissue, and just allow some of that milk to be released. Engorgement, as I said, can happen at any time, especially if you miss a feed, if you're out and about or you're at work or wherever you might be, and you've missed that kind of critical window. Your breasts are going to keep producing milk, and so it's important that if the baby's not there to feed, that mum finds a way of either hand expressing, or using a pump, for example, just to avoid any further issues, which as I said can lead to infected milk ducts and ultimately mastitis. So just following up on some of the sort of tips to avoid engorgement, or to, once if it has happened, how to relieve it. I'll just let you perhaps pause the presentation here and just have a read. And again, these are some really helpful tips that you can pass on to your clients if they do find themselves with some really uncomfortable engorgement. So our next very common issue is that of sore and cracked nipples. And, as we talked earlier about latching issues, in many cases, the sore, cracked nipples really are the result of incorrect positioning or attachment issues. But sometimes there are other issues at play as well, and that can include things like the baby has a tongue tie, for example. So we'll cover that as well in a little while. Feeding with cracked and sore nipples is painful and very uncomfortable, and you can understand why women might not want to feed or continue feeding with that. Again, the problem then is that it can really kind of exacerbate. Not only would she be dealing with sore and cracked nipples, but she then could be dealing with engorgement as well. So again, you can have a good read of this slide yourself, and just looking at ways that you can she can minimize some of those issues, as well as treatment issues as well. So actually one of the most effective treatments for sore nipples is mum's own breast milk. So actually expressing breast milk and rubbing it around the areola and the nipple. There are a variety of nipple ointments and creams out there, like Lansino and other things. The most important thing is that it must be completely safe for the baby to ingest. So no, things like Savlon or I'm trying to think, Vaseline, things like that. So again, if she's not sure, she could ask the maternal child health nurse, she could ask a midwife, even the pharmacist will probably have a good idea of what creams and ointments are safe to put on the nipple that also are safe for the baby to ingest. So have a read of that, and again, there's some hopefully helpful tips there to pass on to clients. So thrush is our next topic and common breastfeeding issue. So thrush, you know, I'm sure some of you have heard about, there's different types of thrush. There's vaginal thrush, for example. It's all the same, you know, infection and source of infection. One of the big issues with thrush is when you're breastfeeding a baby, essentially mother and baby kind of cross-contaminate and infect and reinfect each other. So it can be one of those incredibly frustrating infections to clear up, because no sooner do you seem to be on top of it that there is a reinfection. So symptoms of thrush, nipple thrush, you know, you can see they include sort of pain when you're feeding, cracked, sensitive nipples, also itching sensations in the breast, and sometimes pain as well. But it is possible that you don't have any symptoms. So, you know, it's one of those things that you may not actually realize that you do have. One of the things that you can look for in your baby is that sort of telltale thick white residue on their tongue. Which often does get missed or misread for breast milk residue, which it can be. So again, the best person really to you know, to diagnose that would either be a lactation consultant or you know, or a good GP who knows what they're looking for as well. And really depending on whether or not it's just baby or mother and baby will then determine the treatment as well. So yeah, unfortunately is one of those things which kind of can become very cyclical and can be really quite challenging to get on top of, but it can be done as long as you know, mum is sort of seen and treated quite quickly, and that, you know, it's not left, you know, certainly not ignored for any period of time. So I always wince inwardly when I see this picture because it just makes me feel like I'm in pain just looking at it. So this is a picture of a very, very, very unfortunate woman who has clearly got a very nasty bout of mastitis. It is, you know, as I've mentioned, it's an infection of the milk ducts, and there's lots of reasons why women end up, you know, having it and getting it, but it is very common. Nearly 1 in 5 women will have it at least once. Some women are unfortunate enough to have recurrent mastitis, which is really awful. It usually affects one breast. Again, one of the sort of common, I suppose, mistakes, if you like, that people make, because, and it's understandable because the breast that's affected is so painful, that what they do is that they'll get the baby to only feed from the unaffected breast, and of course it actually makes the mastitis worse. The baby is the best treatment for mastitis because they are able to extract milk more effectively than any hospital grade breast pump. It's not to say that you can only rely on your baby to treat mastitis. 100% not. Women must seek medical attention, and in most cases will require a course of antibiotics to treat it. And it's really important that they don't ignore that, or they, you know, just sort of say, oh, you know, they're going to kind of go for sort of natural remedies, because this is not an infection that you want to mess with. High fever, chills, you know, flu symptoms, it is nasty if it's not got on top of. You know, if you have a client who thinks that that's what they've got or it's developing, tell them, urge them to get on top of it, go and be seen ASAP, get treatment, get antibiotics, get onto it, but also not to stop feeding from the affected breast, to try and, you know, ensure that the baby is continuing to feed, because we need that baby to empty that breast, and they will, in conjunction with the antibiotics, really help to treat that infection. So over the next couple of slides, this one and the next one, you'll see are both about treating mastitis. So again, I will just leave you guys to read those slides and either pause the presentation or just read them after. But again, these hopefully will be useful tips to pass on to your client. So as you can see from this slide, we're going to look very briefly at different types of ties. So again, some of you might have heard of these or potentially experienced them with your own children. Ties can come in a variety of issues in the mouth. The tongue can be affected, the baby's lip can be affected, and the cheek can also be affected. Essentially what a tie is when the baby has an anatomical issue with being able to release and thrust the tongue forward and be able to use all of the muscles freely in their mouth. We don't really know why some babies are born with them and others are not. There has been a theory kind of around for some time that since women were advised to significantly increase their intake of folic acid in pregnancy, because there is very good research to support that folic acid, particularly in the first trimester of pregnancy, significantly reduces the risk of neural tube defects. So really serious congenital defects, including things like spina bifida, etc. So there is very good research to support that. What critics will often say is that folic acid in its synthetic form is far in excess of what humans need, pregnant women need, and that folate, naturally occurring folate, can be found in abundance in many, many foods, and particularly, things like leafy green vegetables and so forth. Excuse me. So there is a connection between folic acid and a greater or an increased risk of ties and other sort of issues as well. So I guess the jury is out on that. Many would also argue that a tongue tie is far less of an issue to deal with than a serious neural tube defect, and I would have to agree with that. Again, as a doula, not our job to diagnose ties. I would encourage the mum, though, your client, to see an IBCLC, a lactation consultant. Really, that is the person who is most skilled and qualified to assess and diagnose a tongue tie. A GP, 100% not. A maternal child health nurse, unlikely. So yeah, it's an LC for something like this. There is actually a very good Facebook group about tongue and lip and cheek ties, and I'll maybe just provide the link for that. And that's again something that you might want to pass on to clients if they're looking for an online support with a lot of very, very good information about it. There's still a lot of controversy around what to do with tongue ties and lip ties and so forth. There are those who sit in the camp of, well, if the baby's feeding is unaffected and there's no issue with breastfeeding, then just leave it alone. And there's the other camp that said, absolutely not. Regardless of how well the feeding is going, if a baby has a significant tie, it should be treated, and it's usually lasered. There's arguments, I guess, for and against both. Those who are very pro, treating and releasing the tie will argue that if the tie is not released, that those infants will grow up and in childhood they will have all sorts of issues, particularly around speech. It will really inhibit their ability to make sounds and to correctly pronounce words. and so forth, and they may have other issues around eating and swallowing, and dental alignment, and a whole lifetime of related issues. I personally am not an expert in this field, but I have spoken over the years to many colleagues who are really very knowledgeable in this space. And really, again, I think as a doula, it's just a good reminder of where we sit in this, and we're really there to provide information and to provide resources and support, and where to go for more expert advice. But I will post that Facebook group because it is very, very good, and there's a lot of really, really knowledgeable health experts who often contribute information in the group.
Hand expression of breast milk is a great way to get milk out of your breast without using a breast pump. It can be especially helpful with early breast stimulation after birth, if you experience engorgement, increasing your milk supply, or getting your baby interested in latching by putting a drop or two of milk on their lips. Watching a visual demonstration is a great way to learn the hand expression of breast milk. So let's get started. Step 1. Massage your breast in a circular motion, working your way all the way around your breast. If needed, hold your breast with your hand on the opposite side of your body for easy access to your areola and nipple. Your areola is the colored area around your nipple. Step 2. With your hand on the same side of your body as the breast you are expressing, place your thumb and index finger on the outside edge of your areola. Your fingers should be directly across from each other as if they were at 12 and 6 or 3 and 9 on the clock. Step 3. Press firmly but gently into your breast with those fingers toward your chest. Step 4. As you press into your breast without lifting your fingers off of your breast, spread your fingers slightly. Step 5. Squeeze your fingers back toward your nipple without sliding them down onto your nipple. This should be a circular massaging motion back towards your chest and out towards your nipple. Things to remember when hand expressing breast milk. If your fingers end up squeezing your nipple, they have slid down too far. Place them back to the outer edge of the areola. It may take several repetitions before milk comes out. You can rotate the position of your fingers around your areola to stimulate different milk ducts. Do not pinch down on your nipple or areola, as this will cause pain and could stop milk flow. Remember, it is a circular massaging motion in towards your chest, then out towards your nipple. If you only express a few drops, you can catch your milk in a spoon or a medicine cup. However, if you plan to express a greater amount, you may need a larger container. For additional help with hand expression of breast milk, meet with your certified lactation consultant.
At some point, most breastfeeding mums will want to start expressing milk, and perhaps building a little bit of a supply in the freezer and storing that milk, so that someone else can give the baby a feed, so that she has more time that she can go out, knowing that there is a good supply of breast milk for the baby. So in terms of options around expressing, as you would have seen from the video just now, hand expression can be quite easy and effective once you've kind of got the hang of it. Realistically, though, most people will find that if they are planning to, in an ongoing way, actually be expressing and storing breast milk, they're probably going to want to invest in a breast pump. They're not super cheap. Private health insurance, some offer discounts, I believe. If you are a member of the Australian Breastfeeding Association, there are some discounts there. They can be hired as well, but again, realistically, if you're going to be using it for 6 to 12 months maybe, then it's absolutely going to work out cheaper to buy one. You of course can buy secondhand. People can buy secondhand, and all they need to do is then buy new tubes and new bottles and breast flanges. So the actual pump itself can be bought secondhand as well, as long as it's in good condition. There's no reason why not. So the There's another Facebook group, which again, I will link in the resources for you. It's called Breastfeeders in Australia. It's an enormous group on Facebook, but a very good one, not judgy, very supportive, very informative, and lots of information and resources there, including I would imagine people selling, you know, breast pumps and those sort of things, as would, you know, other groups that would, you know, some your clients may be on, you know, mums and bubs or parenting groups and that sort of thing. You know, a couple of things I just want to say about expressing is sometimes women will start pumping quite early on. You know, they sort of believe, or maybe, you know, erroneously, that that's the thing, they have to do it. Like there's an expectation, oh, now I'm breastfeeding, I need to start pumping and storing my breast milk. Not necessarily. If you are mainly planning and expecting to feed the baby directly at the breast, then I would say in particularly the first 6 weeks, when it's all about building supply, that in fact that is what they focus on, unless there is a good reason that a lactation consultant has advised that she use a breast pump in those first 6 weeks. I 100% would not encourage a client to start pumping until that supply is well established. You know, but once supply is established, and she, you know, she may choose to start pumping in between feeds. But some people find that when they're pumping, they get very little milk. And then of course what happens is that those women start to panic because they think that their breasts don't have any milk in them. And it's again very important to perhaps reassure clients that what they can produce from pumping has little or no bearing on what their breasts are actually producing and what their baby is consuming. You know, there are many ways to check how well the baby is doing and thriving, you know, beyond weight gain, which is the obvious, but, you know, lots of wet nappies, maybe not as frequently, but obviously stools, but wet nappies are the key. A well-hydrated baby is a well-fed baby. Babies that sleep well, that when they're awake, they're alert, they interact well. So all the sort of signs of a thriving, healthy baby are all great reassurance to a new mum that she's actually making more than enough milk for her baby. The ABA has on its website really good information about expressing and also storing, safe storage of breast milk. And you'll see on the next slide, which I won't sort of bother recording anything on, but again, it's a good one just to pause, and it gives you or clients a good guideline on things like how long can breast milk be left in a bottle on the kitchen table, how long can it be in the fridge, how long can it be in the freezer, and all of those sort of things. How do you defrost it safely, etc. So that's a very good guide to pass on to clients. So that's on the next slide. You can have a look. So as I mentioned at the beginning of today's presentation, that, you know, it's important to cover other ways that baby may be fed. And so the first thing I just wanted to point out is that it is more than possible to do what we call mixed feeding. And that means that the baby is getting a combination of breast milk and formula. And the breast milk may be at the breast or it may be in the bottle as well. So, and there are many reasons why a family may opt to do this, and they include, for example, the baby's not gaining enough weight, or there's some concerns around weight gain, concerns around milk supply, although that unfortunately becomes a bit of a vicious circle, because if the baby is being topped up with formula, then the breasts are not producing as much milk. You know, the whole demand and supply issue is if the baby's not demanding enough and regularly enough, then the breast will stop producing as much milk as the baby needs. So if, you know, out of the sort of say 12 odd feeds a day, maybe 6 or 7 of them are at the breast, then the breast very quickly is only going to produce enough milk for 5 or 6 feeds in a 24-hour period. So it is, again, these sort of decisions, again, we have to go back to, well, what are the needs and motivations of the mum and the family. And if she's just simply being told, oh, the hospital said I need to top up with formula, what I would say is, again, if the capacity and the ability is within that family to have a lactation consultant come over and meet them and discuss all these options, they may find, in fact, that that's not good advice. So, you know, maybe find out a little bit more and sort of dig around and just find out really what's going on with the feeding. But there are legitimate reasons to do mixed feeding for sure. I remember actually in last year's doula training, one of the actually a couple of the women in the group said that in their culture, breastfeeding is very highly valued, and there is an expectation that you continue to breastfeed for a couple of years, but that the breastfeeding happens at home, and if they go out with their baby, then the baby is formula fed with a bottle. And I just thought that was a really interesting sort of, I suppose, cultural norm. So again, those are reasons too, that may be the norm for some of the families that you support. So yeah, so that's another option for feeding. If you have a client who has communicated to you that her preference is to use formula, then I think it's really important and certainly falls within our scope of practice as a doula just to check in with her, ask if she has questions about preparing formula, ensuring that she has the equipment that she needs to do it safely. When you are feeding a baby formula, it is essential that there is safe preparation and sterilization as well of the bottles and the nipples and all the equipment that goes into the preparation of a bottle. It is actually surprisingly difficult to find good, reliable, accurate information around formula feeding that is free of commercial bias. The formula industry is a multi-billion-dollar enterprise. And, despite everything that they will say in their sort of public relations kind of lingo, they have one and only one goal, and that is to sell as much formula as they possibly can. And they have systematically been undermining breastfeeding for decades. There's a lot of information to support that and a lot of research. Am I anti-formula? 100% no. Am I anti-formula companies? Always. Their techniques are underhanded, bordering on really quite unethical in many cases. So the links that I've put here, which you'll be able to click on in the PDF version of the slides, are really good, unbiased and accurate resources. You can see from UNICEF, from the World Health Organization, the NHMRC, for example. And, the goal is really, if families have opted for formula, then of course that's their choice. Let's make sure that they do it safely and that they reduce really any risk to baby of infection bacteria getting into their milk. So feel free to have a look at those and have a read through, but certainly if you're wanting to pass on information to clients, these again are really good resources to send them. So finally, our last little topic is about donor milk. So if you actually look at the World Health Organization's recommendations for infant feeding, they have a sort of a hierarchical list of, from the most optimal method of feeding to the least optimal. And the order in which it goes is breast milk from, mother's breast milk feeding from the breast, mother's breast milk in a bottle, donor milk from obviously from another mother, and then finally formula. So they actually will, donor milk trumps formula. The problem is, though, is that it can be very, very difficult to source, and certainly to source a consistent and reliable supply of donor milk. There are all sorts of ethical issues around this as well. Sharing of breast milk essentially from strangers, although again, many would argue that women have been doing this probably since the beginning of time. We centuries gone by, we've had traditions of wet nurses, for example. Wet nurses breastfed babies that they didn't give birth to. So what are the options for donor milk if mums are really, really desperate to ensure their babies continue to receive breast milk if for some reason they're unable to feed their own baby? So for babies that are really unwell, so either very premature or very sick babies, they are prioritized for our public milk bank. Excuse me, and that's at the Mercy Hospital. The milk goes through a very, very robust screening process. It is also pasteurized. So some of the sort of really great, good things that are in breast milk, don't survive the pasteurization process. But it is, that is really the source of breast milk for those vulnerable babies. I would say in general that if, a mum with a well, thriving infant simply wanting to access donor milk, they would very much be at the bottom of the line there and may not qualify to access it. So where does that leave mums? Well, that's where private breast milk donation comes in. It is illegal to sell breast milk. So the sharing of breast milk is really on an honor system. There are a couple of, well-established groups. These are global organizations, and they have chapters in cities all around the world. There's Eats on Feets and Human Milk for Human Babies. There are also, I know this is, just from my personal experience in working in the space, there are many private midwives who also help with sourcing through clients. So sometimes if a woman's had a home birth and she has a private midwife, she goes to her and says, can you help me with donor milk? And they kind of ask around their networks. But those two groups are really probably the most be the most obvious place to go, and where really the majority of donor milk is listed. So you can either be a woman, a lactating mum who has excessive supply and is willing to donate extra milk, or you may be a mum seeking milk for your baby. So you see posts from both. You see all sorts of things. Women who are donating their milk give very detailed explanations of their diet, their lifestyle. During COVID, the very, very kind of controversial, I have been vaccinated, I'm not vaccinated. You see mothers saying, I will not accept milk that's from a vaccinated mother, or vice versa. So it gets very, very kind of controversial there. It is, as I said, it's informal, it's volunteer-led, no money exchanges hands, and it's really up to the mother herself or the family to make an informed choice and ensure that the milk, if they do choose to accept donor milk, that they are confident that that milk is, is safe and suitable to give to their baby. Of course, there are even more informal situations where it may be a friend or a sibling. Your sister may have had a baby recently, and so you're sharing milk from a known friend or relative. And again, that absolutely goes on and has always gone on. So again, this may or may not be something that your clients are interested in knowing more about, but if it comes up, it's really helpful to know where to point them in the right direction for. So yeah, so that's pretty much covers everything. There's quite a few other little bits and pieces, some articles to read, some websites to look at, some videos to watch, which will kind of round off all the content from today. If any of you are really keen to learn more about breastfeeding and become more skilled in that area, I will post as well. So the ABA have a separate website for health professionals, and on that they often will also promote a number of professional development courses. So not necessary to become a lactation consultant or breastfeeding counselor, but there are other ways to sort of gain more information and sort of to really build your professional skills around breastfeeding education. So just wrapping up today's module. So and you'll see a list of these assignments as well that are impact, but just a few things to read here. So there's a few pages in the Preparing for Birth booklet. There's some good resources and some handouts in your student workbook. And what I'd really like you to do is in terms of building on your master resource list, is I'd love you to please really build out your breastfeeding resources list as well. So not just the online, not just like the ABA, which is of course very important, have that there, but delve a little bit deeper into where drop-in clinics and lactation consultants and so that you've kind of got quite a comprehensive breastfeeding resource list to pass on to clients.